Subcommittee will come to order. The chair will recognize himself for an opening statement. Nearly 15 million seniors, or almost 30% of Medicare beneficiaries, have chosen to enroll in a Medicare Advantage plan, an alternative to fee-for-service or traditional Medicare. Medicare Advantage, or MA plans, offer benefits not provided under traditional Medicare, such as reduced cost sharing, vision and dental coverage, preventive care, and care coordination services. Numerous studies show that MA enrollees enjoy better health outcomes and receive higher quality care than those in traditional Medicare. So, who are MA beneficiaries? Medicare Advantage covers a disproportionate share of low-income and minority seniors when compared to traditional fee-for-service Medicare. 4 in 10 seniors with MA plans have incomes of $20,000 or less. Medicare Advantage is fundamentally about offering seniors the choice of better health care through traditional Medicare. Beneficiaries choose the plans that best meet their individual health needs. And according to the latest CMS National Health Expenditures data, more than half of new Medicare enrollees are choosing Medicare Advantage plans. We should be encouraging seniors to take control of their health care and expanding this proven program. Instead, this administration's policies are harming seniors by reducing their choices of high-quality care through a series of cuts to the Medicare program that began with the Affordable Care Act. According to the Congressional Budget Office, Obamacare cut more than $700 billion from Medicare and spent the money on new government programs not for seniors. CBO also has said more than $300 billion of those cuts come from Medicare Advantage. Last year, CMS imposed regulatory cuts of 4 to 6% on MA plans, resulting in benefit reductions of $30 to $70 per senior per month. And on February 21st, 2014, CMS released its 2015 advance notice outlining changes to Medicare Advantage payment policies, which an Oliver Wyman study estimates will result in an additional cut of nearly 6%. This newest cut is projected to cause seniors to lose an additional $35 to $75 per month in benefits. According to experts, these cumulative cuts from the Democrats' policies on seniors could result in plan exits, reductions in service areas, reduced benefits, provider network changes, and MA plan disenrollment, end quote. The week before last, this subcommittee held a hearing on the administration's assault on Medicare Part D prescription drug plans. Now we're learning about more crippling cuts to Medicare Advantage. Why is the administration dead set on pushing policies that harm seniors and using their Medicare program as a piggy bank to fund other health care programs? Today we will hear from a number of members who have authored legislation that would improve the Medicare Advantage program for seniors. We also have witnesses who can speak to the harm that this administration's policies have done to them. I would like to thank all of our witnesses for appearing today. I'll yield at this point the remainder of my time to the Vice Chair of the subcommittee, Dr. Burgess.
Well, I thank the Chairman for yielding. We do spend a lot of time in Congress talking about the problems in health care. The problem is we're so busy triaging the mistakes that we don't think about the things that are actually working. And Medicare Advantage is one of those things that's actually working. What do we always talk about? We talk about disease management, coordinated care. We've talked about that in this committee in a bipartisan fashion for a long time, but guess what? Medicare Advantage plans are delivering on that promise. The President, however, decided to take money away from a working program in order to fund one that's dysfunctional. The President sold the Affordable Care Act on a foundation of false promises. You can keep your plan. False. You can keep your doctor. Also not true. President Obama told seniors he would use the money from Medicare to fund the Affordable Care Act and at the same time improve Medicare for beneficiaries. In reality, these payment cuts are not going back to Medicare, but instead they're funding other provisions of the Affordable Care Act. Along with less money to Medicare Advantage plans, the Affordable Care Act burdened plans with additional requirements. The most recent proposed cuts to Medicare Advantage are part of a historic strategy of provider cuts that have always backfired. The sustainable growth rate is the leading example. It limits access for seniors, and it doesn't reduce cost. It's time for the administration to shift gears and change strategies. Don't fix what's not broken. It's time for the administration to start addressing the real problem, the Affordable Care Act, and not look for problems that are non-existent. Yield back to the chairman.
Chair, thanks, gentlemen. Now yields 5 minutes for an opening statement to the ranking member, Mr. Plone.
Thank you, Chairman Pitts. Unfortunately, I have to begin today's hearing expressing my disappointment in the tactics and process from your side of the aisle. This hearing has morphed from the future of Medicare Advantage, or MA, into what your side is now calling a legislative hearing, and we clearly have different definitions of what a legislative hearing should look like. You have invited 7 Republican members to come and talk about bills they've introduced or plan to introduce that will affect Medicare in some way. When we were told of this development, there were requests from staff on whether any Democratic bills on Medicare could be included today, and those requests were ignored. In fact, I have a bill on Part D program integrity that is very similar to one presented, but for some reason that bill was not given any consideration. So, Mr. Chairman, one bill in particular is quite egregious. It attempts to gut the coverage provisions of the Affordable Care Act in order to provide billions of dollars to private insurance companies. The others are not new ideas from Republicans. They involve allowing individuals to switch to high-deductible health plans which do nothing but worsen the risk pool for those in comprehensive MA plans. Another bill would reinstate the second enrollment period for seniors, an issue that has already been litigated and determined to be confusing and unhelpful to beneficiaries. And I can go on and on about my concerns here, but most importantly, I wish we could hear from substantive witnesses today on how these bills would weaken, or as the other side claims, strengthen the MA program. But unfortunately, we were not given that opportunity. So I hope that if the chairman intends to move forward on any of these bills, that the administration, stakeholders, and Democratic staff would have an opportunity to weigh in. I don't have to remind you that recent history has shown that nothing becomes law out of this committee without bipartisanship. While the majority of Medicare's 52 million beneficiaries are in the traditional federally administered Medicare program, MA offers beneficiaries an alternative option to receive their Medicare benefits through private health plans. MA has become fairly popular among seniors, with more than a quarter of all beneficiaries now enrolled in such plans across the country. The ACA included quality improvements of MA plans by rewarding plans that deliver high-quality care with bonus payments. Incentivizing quality patient care over quantity of services provided is key to improving health outcomes and reducing the rising cost of health care. The bottom line is the ACA reined in a program whose costs were excessive and put the program on a more sustainable footing. Since passage of the Affordable Care Act, MA enrollment has increased by nearly 1/3, premiums have dropped by nearly 10%, and over 1/3 of MA contracts will receive 4 or more stars, an increase from 28% in 2013. Despite warning cries to the contrary, the program is stronger than ever. Now, today we'll hear from some witnesses about a study commissioned by the plans themselves. They will claim that CMS's recent proposed cuts could devastate the MA market. But I'd like to point out that these are not new cuts. These were expected cuts that bring MA plan payments in line with fee-for-service payments as required by law. And since by law MA plans are paid based on overall growth in Medicare, it's no surprise that when healthcare spending in Medicare slows, payments to MA plans will follow. And we should all think that's a good thing, especially those who continually take aim at the percentage of federal spending on healthcare. So not only were plans prepared for these reductions, Wall Street doesn't seem to think the picture is as dire. In fact, some companies' stocks skyrocketed because the truth is, as more and more baby boomers age into Medicare, and hopefully, unless the Republicans mess it up, a permanent replacement for the SGR is passed into law, the MA program will become even more robust and will continue to be an area of growth for insurance companies. Regardless of the talking points from the other side and industry, I continue to believe that removing plan overpayments is the right policy for Medicare. to reverse course would raise costs for taxpayers and all Part B beneficiaries, drain from the solvency of the trust fund, and expand beneficiary inequities that disadvantage the overwhelming majority of Medicare beneficiaries who remain in fee-for-service. So I look forward to hearing from our second panel today, specifically from Mr. Stein and Mr. Vanderwater, because a debate about how much we pay private insurance companies is overshadowing some important aspects of CMS's work in protecting beneficiaries. We should all work together to strengthen and improve the program and not weaken it. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for opening statement.
Thank you very much. I appreciate it, Mr. Chairman. Thanks for holding this important hearing on how to protect Medicare Advantage. My bill, H.R. 3392, the Medicare Part D Patient Safety and Drug Abuse Prevention Act, will reduce fraud and abuse without negatively impacting Medicare beneficiaries by enacting cost-saving measures employed not only by TRICARE and the state Medicaid programs, but also by private industry. H.R. 3392 creates a safe pharmacy access program to establish a single point-of-sale pharmacy system for the dispensing of controlled substances for high-risk beneficiaries. This will directly address the issue of doctor and pharmacy shopping, where individuals go to multiple locations to fill multiple prescriptions. I'd like to thank my co-sponsor, Mr. Ben Lujan, and then I also want to yield now the balance of my time to Dr. Kathy. Thank you, Mr. Chairman.
Thank you, Mr. Bilirakis. Thank you, Mr. Chairman. I submit for the record a letter to the CMS that Mr. Barrow and I and over 200 of our congressional colleagues have signed. We're concerned about the proposed cuts to the MA plan and the negative impact it will have on seniors. Over 15 million seniors rely on Medicare Advantage, almost one-third of Medicare beneficiaries. These plans are popular because they've been proven to contain cost and improve enrollee health outcomes by focusing on prevention and disease management. CMS is planning to cut MA plans for seniors in Louisiana, for overall seniors by 5.9% in 2015. In Louisiana, that averages out that the MA beneficiary will have about a $55 to $65 cut per month, which of course is $660 to $780 per year in higher premiums, higher cost sharing, and lower benefits for about 200,000 MA beneficiaries in my state. In response, members of Congress are coming out of the woodwork to say to CMS, stop these cuts, protect Medicare Advantage, protect seniors. Now, Mr. Bilirakis will allow me to, I'll yield 1 minute to the gentleman from Georgia, Mr. Barrow.
Thank you, Dr. Cassidy, for yielding time, and thank you for your partnership on this issue. Mr. Chairman, Georgia is home to hundreds of thousands of Medicare Advantage beneficiaries who are worried about the stability of the program. The proposed cuts to Medicare Advantage would amount to a 5.9% cut. These cuts would reduce benefits and increase premiums by $35 to $75 per month for our nation's 15 million seniors with Medicare Advantage. Further cuts to Medicare Advantage would dramatically alter the standard of care that folks have come to rely on. That's why, as of today, 204 of our colleagues have joined Dr. Cassidy and me to warn Administrator Tabner against these proposed cuts. Mr. Chairman, thank you for calling this hearing. I look forward to learning much from the witnesses and working with you to strengthen this vital program. With that, I yield back the balance of my time to Dr. Cassidy.
Would the gentleman yield for 1 second? Dr. Cassidy, right here. Just to welcome our panel and my roommate, Mr. Paulson.
Thank you, and without objection, the letter that Dr. Cassidy submitted will be entered into the record. We have two panels today. The first is a member panel, and I'll introduce them at this time, and they'll speak in this order. First, the Honorable Eric Paulson, member of Congress from Minnesota. Then the Honorable Jeff Denham, member of Congress from California. The Honorable Dennis Ross, member from Florida. The Honorable Keith Rosfus, member from Pennsylvania. And the Honorable Jackie Walorski, member from Indiana. Thank you very much for coming today. Your written testimony will be made part of the record. You'll be each given 5 minutes for your opening statement. So, Chair, recognize Mr. Paulson for 5 minutes.
Thank you, Mr. Chairman, Chairman Pitts, and Ranking Member Pallone. I want to thank you for holding this hearing today to ensure that our seniors and their Medicare Advantage MA plans are protected from unnecessary cuts. I've received many calls and emails and letters from my constituents, my seniors in my district, who are concerned about cuts to the Medicare Advantage program and the impact that it could have on their health care plans. The Medicare Advantage program is a resounding success in providing coordinated care for seniors with better quality, more choices, and greater savings for millions of Americans. Over 175,000 seniors in Minnesota are enrolled in an MA plan, including more than 50,000 in my congressional district alone. More than half of Medicare eligible seniors in my district have opted to enroll in MA plans rather than the traditional fee-for-service system. Nationwide, millions of Medicare beneficiaries have chosen a Medicare Advantage plan because they value access to better quality of care, innovative services, and additional benefits. The MA program enjoys high patient satisfaction and will reduce the cost of Medicare in the long run by providing evidence-based, coordinated care for our seniors. Unfortunately, the future viability of the MA program is at risk. The MA program is facing Obamacare-mandated payment cuts, the health insurance tax, and the coding intensity cut in last year's fiscal cliff deal. The latest threat is the 12% cut in regulatory cuts that have been proposed the last 2 years, including a 6% cut to the plans this year. Seniors in my district could pay as much as $900 more per year as a result of these cuts. Many might lose benefits, and some could lose their plan completely. The administration is also attacking Medicare Advantage's innovative delivery system reforms like in-home risk assessments that have been absent in fee-for-service. Home risk assessments are clinical encounters in a beneficiary's home designed to prevent, to detect, and to treat chronic diseases to reduce hospital admissions, decrease readmissions, and improve the overall quality of life for seniors. And instead of increasing costs for seniors and hindering plans' ability to utilize innovative models of care, Congress should be providing more flexibility to plans and make it easier for seniors to participate in MA-like plans. That's why I have authored legislation, Mr. Chairman, H.R. 4177, to allow Medicare beneficiaries to contribute their own money to their medical savings accounts, these MSAs. Medical savings accounts are health savings accounts for Medicare Advantage plans. They allow seniors to utilize money in the accounts to pay for health care costs, including some costs that aren't covered by Medicare. Right now, seniors can't contribute their own money to their MSA like they can to a health care savings account. But by giving seniors more flexibility with these accounts, we will empower them to take charge of their own health care decisions. And this will strengthen the Medicare Advantage program, and it will reduce health care costs for seniors and the system in the long term. I encourage the committee to take a look at this legislation and maybe bring it up for consideration. Thankfully, Mr. Chairman, there is hope that we can avoid these additional cuts to Medicare Advantage. Over 200 members, as was mentioned in earlier opening statements of both parties, including myself, sent a letter to the administration opposing these proposed cuts. We must protect our seniors and their health care plans by opposing these cuts. I sincerely appreciate the opportunity to testify and commend the committee for their work to protect seniors in Minnesota and around the country.
Chair, thanks, gentlemen. Now recognize Mr. Denham, 5 minutes for an opening statement.
Chairman Pitts, Ranking
Jeff, Chairman, I think the transcriber's trying to get the microphone.
I'm sorry. Are you okay? All right, you may proceed.
Can you not hear me? All right. This is straightforward legislation. It will serve to inform the more than 14 million seniors currently enrolled in Medicare Advantage about how the Affordable Care Act is affecting the health care plans that they rely on every day. For over 60,000 seniors who enrolled in Medicare Advantage in the counties I represent, the Medicare Advantage program has been tremendously successful in improving health outcomes when compared to traditional Medicare fee-for-service. This is because the Medicare Advantage model emphasizes preventative services and managed care to keep beneficiaries healthy. Medicare Advantage plans also limit out-of-pocket costs, protecting vulnerable seniors from the threat of bankruptcy due to the complicated medical conditions. Maybe this is why the survey of Medicare Advantage beneficiaries found that 90% were satisfied with their coverage. 92% were satisfied with their choice of doctor, and 94% were satisfied with the quality of care received under Medicare Advantage. The 14 million seniors enrolled in Medicare Advantage plans nationwide deserve to know the massive government overhaul of our health care system was paid for in part by the $300 billion in cuts to Medicare Advantage plans and a health insurance tax that has just started this year. The combined effects of these payment cuts and the new health insurance tax are already being felt through canceled plans, reduced benefits, and increased copays. During this year alone, beneficiaries in over 2,000 counties will have fewer plan options compared to 2013, and on average will see their annual costs increased by nearly 10%. Unfortunately, the impact will only grow with time. As an example, in 2015, seniors in Stanislaus County, in my district, can expect to pay an additional $90 per month or $1,080 per year for their Medicare Advantage plan. A large percentage of the 33,000 enrollees in Stanislaus County are low-income individuals earning under $20,000 per year. This rate increase will enforce them out of participating in the Medicare Advantage program altogether. Did the 111th Congress really mean to cut Medicare Advantage in order to subsidize the Affordable Care Act? Whether Congress meant to or not, seniors have a right to know that these changes are coming so that they can actually plan and budget for these increases that they're going to see. Mr. Chairman, as you are well aware, there have been at least 37 major alterations to the Affordable Care Act since it was enacted. Some of these were done in cooperation with Congress, yet on 20 separate occasions, after it became clear that the implementation of the law was failing the American people, the administration moved unilaterally to change the law. These delays and alterations are proof that the Affordable Care Act is not working as intended. Unfortunately for our seniors in our districts, while the promises of health care remain unfilled, the cuts and taxes on Medicare Advantage plans required to finance the law are moving forward as scheduled. Congress must act to protect the future of Medicare Advantage by repealing the cuts and taxes on the program. This would prevent the immediate erosion of health security for Medicare Advantage beneficiaries while we work to replace the Affordable Care Act with a health care reform that puts patients and seniors first. Until we can enact such legislation, seniors have the right to know why their Medicare Advantage plans are being impacted, and I urge this committee to support this bill. I would also like to thank the 60 Plus Association and the Association of Mature American Citizens for their support of this legislation and would like to submit their letters for the record.
Without objection, so ordered. Chair thanks the gentleman. Now I recognize the gentleman from Florida, Mr. Ross, 5 minutes for opening statement.
Thank you, Chairman Pitts and Ranking Member Pallone Committee for taking the time today to hold this hearing to highlight the significant threat facing the Medicare Advantage program. In 2012, healthcare spending in the United States accounted for 17.2% of our nation's economic output, equal to $8,915 per person. Mr. Chairman, these statistics tell me that for a country with arguably the best health care in the world, we have yet to properly align patient and provider incentives to enable our health care system to be cost-efficient, highly accessible, and ultimately to achieve self-sustaining cost containment with little need for government intervention. More than 3.5 million Medicare beneficiaries reside in my home state of Florida. 1.2 million of these beneficiaries have chosen a Medicare Advantage plan over Medicare's traditional and more costly fee-for-service structure. In fact, since 2008, the state of Florida alone has seen a 30% increase in the number of Medicare Advantage plan beneficiaries, while currently 30% of our nation's Medicare population have opted for a Medicare Advantage plan, serving as a clear testament to the high level of patient satisfaction the program has achieved. Among the many satisfied Medicare Advantage plan beneficiaries in the state of Florida are Michael and Sandra Cox from my hometown of Lakeland, Florida. Michael and Sandra did what so many Medicare Advantage plan beneficiaries have done since January 1, 2014, writing to their members of Congress expressing a mix of anger, confusion, and panic at the senseless cuts that have been made to this effective program. Sandra and Michael wrote, quote, "Please explain the logic of the Obamacare cuts to Medicare Advantage. My husband and I have never experienced such a high level of satisfaction with our health coverage as we have with our Medicare Advantage plan, and with all with a much cheaper monthly premium." Unfortunately, Michael and Sandra learned on January 1st that the doctors that they had been seeing for more than 10 years were no longer available under the Medicare Advantage plan as a result of the continued cuts to the program. They would face the full out-of-pocket costs should they choose to continue seeing those providers that they had come to know over the last 10 years, and their health status they treated so well. Mr. Chairman, was it not the administration's goal to ensure patients develop a relationship with their provider, resulting in better prevention and a more consistent continuum of care? Unfortunately, these cuts to Medicare Advantage, like so many other health care-related actions by this administration, are contradictory to the purported message. Even more baffling, past cuts have already crippled innovative programs like home health visits, instituted by Medicare Advantage plan sponsors to ensure our seniors are able to maximize the value of health care services they receive. Going forward, additional cuts of this magnitude will devastate medical innovation in areas like telehealth that show great promise for increasing efficiency and cost containment in Medicare Advantage and the healthcare system at large. Overall, healthcare spending and utilization habits are a critical threat to America's declining fiscal health. If we are to successfully curb healthcare costs, we must preserve and enhance the Medicare Advantage program because of its proven ability to achieve cost efficiency while maximizing patient access to high-quality health services and providers. To be more specific, data collected between 2003 and 2009 showed service utilization rates in areas like emergency department use and ambulatory surgery were 20 to 30% lower among Medicare Advantage beneficiaries than traditional Medicare. Overutilization of healthcare services, however, is only one facet of healthcare cost growth tempered by the Medicare Advantage plan structure. Although this current administration has tried to discredit the power of market competition in creating organic, self-sustaining incentives for patients, providers, and insurers alike, the facts always prevail. Artificial market controls put in place by the federal government lead to more out-of-control health spending, as we have seen time and time again. As far back as 1995, health economists have shown that combining coverage like that offered by Medicare Advantage with appropriate patient incentives leads to an avoidance of excessive doctor visits and tests, as well as more engaged patients seeking the best value for the health service they need. In this same vein, I was proud to introduce H.R. 4180, the Preserving Health Savings Accounts for Medicare beneficiaries, which would allow for this consistently proven economic strategy for reducing health care costs across the spectrum. My legislation would incentivize younger Americans to establish health savings accounts with the promise that upon being Medicare eligible, they are able to transfer the HSA funds into a Medicare savings account. Simple enhancements like this one will help both Medicare Advantage and the entire healthcare system achieve organic alignment between insurers and patients and providers and creating a powerful self-sustaining cost containment pool. Patients have more control over their healthcare dollars, increasing awareness of reasonable health service costs and quality options, while also actively engaging providers to offer the highest quality service at the lowest reasonable cost in order to earn a patient's business. Mr. Chairman, this is what value in healthcare looks like. Unfortunately, through continued cuts to the Medicare Advantage program, this administration will eliminate any possibility we currently have to build upon the Medicare Advantage program success in curbing health care costs, and I yield back.
Chair, thanks, gentlemen. And now the Chair is proud to introduce from the state of Pennsylvania, Mr. Rothfuss. Recognize him for 5 minutes for opening statement.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, thank you for having me here today to testify about H.R. 2453, the Medicare Beneficiary Preservation of Choice Act. I am very pleased to discuss this bipartisan legislation that Congressman Kurt Schrader and I introduced in June of 2013. Enacting H.R. 2453 is one small fix we can make to Medicare Advantage that can have a big impact on the lives of the seniors utilizing the program in our districts. It simply restores the open enrollment period that existed prior to 2011. This open enrollment period permitted seniors to change Medicare Advantage plans once between January and March if needed. It essentially lets seniors test drive the Medicare Advantage plan they would have just selected and change plans if it turns out that the plan is not working for them. H.R. 2453 is about choice and fairness for seniors. It is about empowering them to make decisions about their health care needs. Restoring the January to March open enrollment period also makes sense in light of the 2014 Medicare Advantage cuts and the new cuts just proposed by CMS. Last November, the Wall Street Journal reported that one of the nation's largest Medicare Advantage providers had dropped thousands of doctors from network due to significant changes and pressures in the healthcare environment. This is significant because seniors may not have known about the change in time to adjust their decisions during the October to December enrollment period. So if they like their doctor, seniors may be finding out just now that they cannot keep him or her because they are no longer included in the plan. Passing H.R. 2453 and restoring the 90-day open enrollment period during the first quarter of the year would let seniors react to these types of plan changes, many of which are driven by the harmful cuts to Medicare Advantage that we see happening as a result of the Affordable Care Act. H.R. 2453 is a patient-centered option for improving Medicare Advantage. It will provide choice for seniors and will ensure that they have access to the doctors they know and trust. That is why it is supported by America's Health Insurance Plans, the Association of Mature American Citizens, and the 60+ Association. The subcommittee members and its chairman should be thanked for their efforts to strengthen Medicare Advantage. Medicare Advantage delivers quality health care and peace of mind with consistently superlative satisfaction ratings from participants. Preserving the program and preventing more cuts to Medicare Advantage is a top priority for me and for the seniors in Pennsylvania's 12th district. Incidentally, in my district, utilization of Medicare Advantage is in excess of 60%, more than double the national rate. Additional cuts to Medicare Advantage will lead to higher out-of-pocket costs, reduced benefits, and fewer plan options. Instead of limiting access to a successful program which 9 out of 10 seniors are satisfied with, we should be empowering them to make choices about what best suits them. We should make sure seniors have access to the health care providers they know and trust. Instead of cutting Medicare Advantage, we should be finding solutions to lower costs for seniors and sustain the program for the long run. I had an incident this past Monday with a senior in my district at a restaurant. She was the hostess, and she expressed to me a real concern about the cuts to Medicare Advantage, personally impacting her. I asked her to call my office and give us more background because I want to tell that story here in Washington. And she simply looked at me and said, "Why? So the politicians can accuse me of lying?" That's what's happening out there in the country, and people are very concerned about what's happening with Medicare Advantage. I thank the chairman, and I yield back.
Chair thanks the gentleman, and now introduces the gentlelady from Indiana, Ms. Walorski. I recognize her 5 minutes for opening statement.
Thank you, Mr. Chairman. Chairman Pitts, Ranking Member Pallone, members of the subcommittee, it's an honor to be here today, and I thank you for holding this hearing to examine Medicare Advantage, a vital program that's critical to the health and well-being of many of our nation's seniors. Over 15 million Americans depend on Medicare Advantage. Through this popular program, seniors and individuals with disabilities are able to select a private health plan of their choice that provides affordable, comprehensive coverage, disease management, and care coordination. The Affordable Care Act and other regulatory changes have placed significant financial strain on this program, the brunt of which will be borne by the seniors we've promised to protect. Cuts to Medicare Advantage mean higher out-of-pocket costs, a more limited choice of doctors, decreased management of chronic conditions, and decreased coverage for dental and vision services. In my home state of Indiana, 22% of Medicare-eligible Hoosiers have chosen to enroll in Medicare Advantage, and enrollment in my district is even as high as 27%. This program serves my constituents well, and I'm deeply concerned about how cuts will impact seniors in the Hoosier state. Marcia from Mishawaka told me she's very pleased with her Medicare Advantage program. She loves the quality of the services provided and the prescription drug program that's included. She's worried about the looming cuts because she wants to keep her current doctor. As a senior citizen living on a fixed income, it's important that her premiums remain low, and she wonders who will take care of seniors if the cuts continue. 87-year-old Phyllis and her 93-year-old husband, Owen, like the peace of mind that comes with knowing they'll receive excellent care through their current health care plan. Back in June, Phyllis fell and broke her hip. She was promptly picked up by an ambulance, admitted to surgery, and received excellent follow-up care and rehab. Her Medicare Advantage plan took care of the costs. Owen had a pacemaker inserted last year, which was also taken care of by his MA plan. Originally, there was no premium for this plan. Now they pay $34 a month. Although $34 a month may not seem like much, Phyllis told me if their premiums become too high, they'll have to cut back on other necessities. Phyllis and Owen never imagined the Affordable Care Act would negatively impact them, especially when the president said that you can keep your health care plan if you like it, but now their health care plan is in jeopardy too. Medicare Advantage plans are particularly critical to low-income and minority beneficiaries. According to a study by Americans Health Insurance Plan, 1 of 5 of those enrolled in Medicare Advantage are minorities, and 41% of enrollees have annual incomes of less than $20,000. Cuts to the program have the potential to disproportionately affect these most vulnerable populations. That's why I introduced H.R. 4211, the Advantage of Medicare Advantage for Minorities and Low-Income Seniors Act of 2014. This legislation directs the Government Accountability Office to study the number of minority and low-income seniors enrolled in Medicare Advantage and to assess the impacts of Medicare Advantage payment reductions resulting from the Affordable Care Act and other administrative actions. Studies show that enrollees in Medicare Advantage have lower hospital readmissions, receive higher quality of care, and enjoy better health outcomes as compared to their counterparts in traditional fee-for-service Medicare. Medicare Advantage serves as a vital source of coverage for low-income and minority beneficiaries. On behalf of my constituents in the 2nd District and all Hoosiers, I look forward to working with both Congress and the administration to keep the promise to maintain the integrity of Medicare Advantage. Thank you for the opportunity to appear before you this morning.
Chair, thanks, gentlelady. And again, thanks the members for the testimony on your initiative. We'll be happy to work with you on those. Thank you for taking time out of your busy schedules to appear before us today. There'll be no questions. I'll excuse panel 1 at this time and call the second panel to the table and introduce them in the order that they will make presentations. First, Mr. Frank Little, a Medicare beneficiary with a Medicare Advantage plan. Secondly, Dr. Mitchell Liu, CEO and Chief Medical Officer of Prospect Medical Systems. Thirdly, Mr. Glenn Giese, Principal, Oliver Wyman Consulting Actuaries. And then Ms. Judith Stein, Executive Director, Center for Medicare Advocacy. And finally, Dr. Paul Vandewater, Senior Fellow, Center on Budget and Policy Priorities. Thank you all for coming today. Your written testimony will be made a part of the record, and we will give each of you 5 minutes to summarize your testimony. Mr. Little, we'll start with you. You're recognized for 5 minutes. Would you press the button, make sure that's on? Pull it close to you.
Okay.
Yeah.
My first appearance.
That's all right. Pull it a little closer. There you go.
Chairman Pitts and members of the committee, thank you for providing me this opportunity to testify about my personal experience with the Medicare Advantage plan. My name is Frank Little. I am a retired small business owner from Virginia Beach. I am 70 years old. My wife and I have been enrolled in 3 different Medicare Advantage plans over the past 5 years. We have received high quality, affordable coverage through our Medicare Advantage plans, but we are concerned that our plan choices are shrinking due to the deep funding cuts in this program. When I first became eligible for Medicare, I had a choice of 4 different Medicare Advantage plans that offered prescription drug benefits with no additional premiums. Over the years, uncertainty about the program funding has forced several of these plans to either withdraw from my area or increase premiums. Today, I am enrolled in a Medicare Advantage plan offered by Humana, which is still the only plan in my area offering a plan that includes prescription drug coverage with no additional premium. I am very satisfied with my Medicare Advantage plan and feel fortunate to have this option. To help the committee understand why my Medicare Advantage plan is important to me, I want to explain my experience over the last several years. I have had 3 major medical problems since I retired. I have had open heart surgery, colon cancer, and a medical procedure on my lungs. I estimate that medical bills for these conditions have totaled approximately $750,000 over the last 5 years. And I am pleased to tell you that my Medicare Advantage plans have covered almost all of these expenses. I have only paid a few $100s in out-of-pocket cost. Without my Medicare Advantage plan, I would have faced high deductible and 20% co-payments if I had not been enrolled in an original Medicare program. Like many seniors, I live on a fixed income, and such high costs would have devastated impact on my budget. I also want to emphasize that my Medicare Advantage plan has allowed me to receive high-quality care from my personal physician, from outstanding specialists, and from an excellent hospital in my community. Other seniors in my communities have several stories to tell about the quality coverage they receive through their Medicare Advantage plan. We appreciate that our plan provides prescription drug coverage as part of our medical coverage, while also taking care of our expenses to ensure that our out-of-pocket expenses are affordable. My message to Congress is that I want you to make sure that Medicare Advantage continues to be a strong and adequately funded program. I'm asking you to block any additional funding cuts. I am counting on both Congress and the Obama administration to do the right thing and protect this program from any further funding cuts. In closing, I want to say that I love my Medicare Advantage plan, and I will be deeply disappointed if I lose my plan. Thank you for considering my comments on this important issue.
Chair thanks the gentleman. Now recognize Dr. Liu, 5 minutes for an opening statement.
Thank you, Chairman Pitts, Ranking Member Pallone, and members of this committee for the invitation to testify today. My name is Dr. Mitchell Liu, and I am part of the CAPG National Board, and am pleased to testify on behalf of CAPG, which is the largest association in the country of physician organizations that practice capitated coordinated care. CAPG members represent 160 medical groups in 20 states and serve 1.2 million Medicare Advantage enrollees. I also address you as a physician who practiced for 10 years before transitioning to a physician executive role 15 years ago. I am CEO of Prospect Medical Group, and which is an IPA model with over 4,500 physicians in 3 states and serving 225,000 members. This model allows us to contract with smaller physician practices under the umbrella of one large organization. For background, Prospect Medical began in 1985, and we have evolved over the years, and we now offer a full range of coordinated care services and programs, and this has resulted in better value to our seniors. It's better care, better health, with cost control. Prospect has grown, and we now have physicians and hospitals in California, Texas, and Rhode Island. I come to emphasize the merits of Medicare Advantage and the coordinated care model, and the need to preserve the financial support for Medicare Advantage and to continue our investment into the model. Medicare Advantage takes a population-based payment approach, which reduces the high utilization incentives of traditional Medicare. It is value over volume. It's team-based. Physician organizations are structured to provide the best care at the right time in the most appropriate setting. Seniors are managed across an entire continuum of care. They get preventive services, home visits, high-intensity case management for the sickest members, chronic disease management, palliative care. It allows for innovation. Physicians are held to performance standards, and they receive quality incentive payments. Social and behavioral services are also delivered in a coordinated manner. The impact of Medicare Advantage is better care. Lower admissions, lower readmissions, lower lengths of stay, better outcomes, higher member satisfaction, more benefits, and higher interest among new seniors. And that's particularly important for the low-impact seniors the low-income seniors who like the enhanced benefits, and they need the enhanced benefits. Medicare Advantage has grown by 30% over the last 3 years, and now 50% of new Medicare enrollees are choosing Medicare Advantage. The proposed reductions and cumulative cuts pose very serious threats. It will cause an erosion of the coordinated care infrastructure, higher cost sharing, which will have a profound impact on the lower income and minority seniors, fewer benefits. These cuts will undermine all of the progress that we've made in developing the healthcare delivery system. Medicare Advantage should be the infrastructure that all of the newer models in fee-for-service should use to build coordinated care, such as the ACOs and the medical homes. I urge Congress and the administration to find ways that will strengthen, not cut, Medicare Advantage. Develop policies that will promote population-based payments. Medicare Advantage should be the foundation upon which the entire healthcare delivery system builds coordinated care. As you develop Medicare and fiscal policy, I ask that you consider all that Medicare Advantage has to offer and know that additional cuts will have very serious consequences on the coordinated care model and the seniors that it serves. Without Medicare Advantage, we have very little chance to transform our healthcare delivery system. Thank you very much, Mr. Chairman, and I look forward to your questions.
Chair thanks the gentleman, and now recognize Mr. Giese, 5 minutes for an opening statement.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee. Thank you for the opportunity to testify. I am Glenn Giese, a senior principal with Oliver Wyman Actuarial Consulting. My testimony today will focus on the findings of a recent analysis by Oliver Wyman, commissioned by America's Health Insurance Plans, which estimates the potential impact of funding cuts that would be imposed by Medicare Advantage program by proposed changes to the MA payment methodology in 2015. Our analysis focused on the combined impact of preliminary payment policies and regulatory changes announced by CMS on February 21, 2014 in its 45-day notice and draft call letter, cuts included in the Affordable Care Act and other legislative provisions addressing MA payments. Specifically, we identified 9 different factors that would impact MA payments in 2015, most of which would reduce payments. A detailed explanation of these factors is outlined in the appendix to my testimony. We have calculated that the projected overall impact of these policies would be to reduce MA payments by an estimated 5.9% in 2015. We note that the impact of these changes on individual plans will vary based on a number of factors, including the geographic area in which the MA organization participates. We further estimate that the 5.9% funding cut translates into a potential reduction of $35 to $75 per month, or $420 to $900 for the year in funding that will be available to support the benefits of MA enrollees in 2015. These cuts, if implemented, will represent a second consecutive year of deep cuts in MA funding. Due to a combination of legislative and regulatory policies implemented for 2014, MA payments already have been cut by 4 to 6% this year, resulting in cost increases and benefit cuts of $30 to $70 per month for beneficiaries. If the new changes proposed by CMS are implemented, the program would be hit by a double-digit cut over just a 2-year period, causing cost increases and benefit reductions that could total as much as $1,740 per enrollee over 2 years, according to our projections. The MA cuts proposed for 2015 could have far-reaching implications for over 15 million seniors and individuals with disabilities who are enrolled in MA plans. In our report, we explain that these cuts could result in a high degree of disruption in the MA market, including the potential for plan exits, reductions in service areas, reduced benefits, provider network changes, and disenrollment from MA plans. We further caution that the proposed funding cuts would disproportionately affect beneficiaries with low incomes, including the 41% of MA enrollees who have annual incomes below $20,000. For these beneficiaries, the potential increase in out-of-pocket costs resulting from cuts would constitute a significant burden. Another serious concern we highlight is that individuals who utilize health care services the most would adversely be affected if they lose their MA plans and are forced to move back to the Medicare fee-for-service program with its higher cost sharing and lack of coordinated care. This is a particular concern for enrollees in special needs plans that serve beneficiaries who have severe or disabling chronic conditions or who reside in institutions. For example, chronic care SNPs offer services that are tailored to meet the specific medical needs of patients with diabetes, cardiovascular disease, and other conditions. The loss of these specialized services would be a serious blow to beneficiaries whose medical conditions require customized treatments of care. Thank you again for the opportunity to testify, and I encourage the subcommittee and Congress to consider the findings of our analysis as you communicate with CMS about its proposed payment policies and regulatory changes to the MA program for 2015.
Chair, thanks to the gentleman. Now recognize Ms. Stein, 5 minutes for an opening statement.
Chairman Pitts, Ranking Member Pallone, and distinguished members of the subcommittee, thank you for inviting me to testify. I'm Judith Stein, founder and executive director of the Center for Medicare Advocacy. I have dedicated my legal career to representing Medicare beneficiaries exclusively since 1977. The Center is a private nonprofit organization based in Connecticut and Washington, D.C., with offices throughout the country. We respond to over 7,000 calls and emails from Medicare beneficiaries and their families each year. Medicare beneficiaries had had the option to enroll in private health plans since the 70s. The Medicare private plan option, now called Medicare Advantage, prior Medicare Plus Choice, was supposed to provide equal or better coverage for beneficiaries at a lower cost than traditional Medicare. Unfortunately, that has not been the case. As you know, in fact, on average, private MA plans, Medicare Advantage, are paid significantly more than it would cost to provide similar coverage in traditional Medicare. Now, we recognize that MA plans can be a viable option for some enrollees, but I must remind the committee that the vast majority, 36 million or more older and disabled people, are enrolled in traditional Medicare, which is no longer a fee-for-service program. And 50% of all Medicare beneficiaries have incomes under $23,500 a year. At the center, we regularly hear from families and individuals who have had problems with their MA plans. One of the most frequent issues we encounter concerning MA coverage relates to post-acute care. For example, over the last year, the center has received complaints from across the country about MA plans that have denied coverage for skilled nursing facility care, despite the fact that the individuals at issue were receiving nutrition through feeding tubes, which under federal regulations and common sense is a skilled service. We've heard this from Ohio, Pennsylvania, Minnesota, and of course Connecticut. In fact, one of the beneficiaries who called us, or the family did, was granted coverage on appeal, but the MA plan actually appealed that case into federal court. And we, a nonprofit that is not paid by our clients, had to go to federal court to make sure that that individual and the others like him in that MA plan would get coverage and care. These issues are not new and occurred even at the height of MA overpayments, when plans were paid at an average of 114% of the amount traditional Medicare would spend on a similar individual. In 2009, for example, the center had to take another case to federal court in order to obtain coverage for an individual receiving tube feeding. But the MA plan was so determined to deny coverage, it continued that case into federal court in Minnesota. One of the most important health considerations for individuals is the ability to choose one's doctors and healthcare providers. This is the choice that people really care about. By design, as you know, MA plans contract with a limited network of providers to care for enrollees. Some coordinate care, but that is far from the normal course we have found with our beneficiaries over the 30-plus years I have done this work. For example, a Connecticut resident was referred to us by his congressman because he had almost $100,000 in outstanding medical bills for his recently deceased wife that would have been covered had he been in traditional Medicare. That is because he traveled to Florida to be with his daughter where his wife fell. And while her fractured hip was taken care of and paid for by the plan, it turned out she had a brain tumor, and all the services related to the brain tumor were not covered by the MA plan. Sometimes Medicare Advantage enrollees face barriers close to home. When MA plans change their provider networks, as they often do annually, enrollees often have to make sure that their doctors will be in the plan in the coming year. As you may know, the largest plan in our state of Connecticut and in New York, Ohio, and Florida cut many, many providers, 2,250 doctors and healthcare facilities in Connecticut alone, including Yale New Haven Hospital, where my mother, who is on traditional Medicare, recently had urgently needed neurosurgery, which she would not be able to have if she was in a Medicare Advantage plan. Neither physicians nor Medicare patients in that plan, the largest in Connecticut, and in Ohio, Florida, New York, were given adequate notice regarding these extraordinary provider cuts. In addition to the concerns raised for Medicare beneficiaries by MA networks, too many plans fail to provide adequate coverage and access to care when enrollees are seriously ill. While I am grateful for the care that my co-presenter has received from his MA plan, too often we find that when people become truly ill or injured, they are less satisfied with their MA plan. That has been the case with my uncle just this year, my mother's brother, who's 92 and has been in an MA plan all these years, despite my protestations. He is now not receiving coordinated care or the care he needs.
Can you wrap up, please?
Instead of focusing on how much Medicare payments are being cut, which is not really a cut. Congress should focus on making sure they provide what we're paying for. It's simply unfair to ask beneficiaries and taxpayers to shoulder extra payments to private plans that truly don't provide uniformly better value. Enrollees on poor health often receive less coverage, and all have less options of providers. Thank you.
Chair, thanks, the gentlelady. Now recognize Dr. Van de Water, 5 minutes for an opening statement.
Mr. Chairman, Ranking Member Pallone, and members of the subcommittee, I appreciate the opportunity to be with you this morning. My statement reviews the role of private health plans in Medicare, identifies the factors that will hold down payments to Medicare Advantage plans in 2015, and explains why the administration and Congress should reject demands from some quarters to freeze Medicare Advantage payment rates in 2015 at their 2014 levels. For 40 years, Medicare beneficiaries have been able to receive their benefits through private health plans. And as you heard, in 2014, 29% of beneficiaries are enrolled in a private health plan through Medicare Advantage. And virtually all beneficiaries have access to such a private plan. The remaining 70% or so of Medicare beneficiaries are in traditional Medicare. Congress's advisory body, the Medicare Payment Advisory Commission, has long recommended that Medicare's payment system be neutral, favoring neither Medicare Advantage plans nor traditional Medicare. But in recent years, the system has been substantially tilted in favor of private plans, the result of a large increase in MA payments enacted in the 2003 Medicare prescription drug law. In 2009, Medicare paid MA plans 14% more per enrollee than what it would have cost traditional Medicare to cover comparable enrollees. The Affordable Care Act is gradually reducing MA payment rates to bring them more in line with payments in traditional Medicare. This year, in 2014, Medicare Advantage payments average only 6% higher than the levels in traditional Medicare. These overpayments, I must add, drive up premiums for beneficiaries and weaken Medicare's finances. The Centers for Medicare and Medicaid Services has recently announced preliminary 2015 payment policies for Medicare Advantage plans. Although the Health Insurance Industries Trade Association, AHIP, says that the CMS announcement includes new proposed cuts, the agency, CMS, is simply applying current law. The announced payment policies reflect 4 factors that will hold down MA payments in 2015. First, CMS continues to phase in the payment reductions that health reform requires, which curbs some, but as I said, not all, of the excessive payments to MA plans. Second, since MA payments are tied in part to the cost per enrollee in traditional Medicare, the continued slowdown in fee-for-service spending lowers MA payment rates. Third, CMS is implementing more accurate risk adjustment procedures. As health reform requires, it will modestly reduce MA payments to address the problem of upcoding. Also, CMS will no longer include diagnoses identified during a home assessment visit rather than a clinical encounter in determining an enrollee's health status, since these tend to make enrollees appear sicker than comparable enrollees in traditional Medicare. And fourth, ending a demonstration project that pays higher quality bonuses to some plans will effectively lower payments in those plans in 2015 compared to 2014. Now, AHIP and other interest groups charge that the preliminary 2015 payment policies will substantially increase costs to MA participants and will reduce the choice of plans. They ask that MA payment rates be frozen in 2015 at their 2014 levels. But I would argue that the administration and Congress should reject those demands. The predictions of doom and gloom are greatly exaggerated. AHIP issued these same warnings about the MA payment cuts that were made in 2014, but MA enrollment, as you have noted, has nonetheless reached record levels. And the Congressional Budget Office projects that MA plans will continue to thrive despite further payment cuts. Nationwide, the number of plans available dropped by only 3% in 2014, a small change that reflects both the offsetting effects of newly entering plans and those departing the market. Plans also responded to the payment reductions by becoming more efficient. The unweighted average of monthly premiums for MA plans with prescription drug coverage actually fell from 2013 to 2014 and is lower today than in 2011 or 2012. And again, this is despite the payment reductions. Wall Street certainly isn't pessimistic about Medicare Advantage. In the wake of the CMS announcement, shares of Humana, the second largest insurer in the MA market, recorded their biggest single-day increase in 4 years and reached their highest level in more than 30 years. Standard & Poor's overall index for managed healthcare plans also climbed. Finally, preventing overpayments to Medicare Advantage plans is sound policy. Along with the other cost-saving provisions in the Affordable Care Act, eliminating overpayments reduces premiums for all beneficiaries, including the large majority who are not enrolled in MA plans, and extends the solvency of Medicare's Hospital Insurance Trust Fund. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. That concludes the opening statements. We'll begin questioning. I'll recognize myself 5 minutes for that purpose. Mr. Little, I'll go first to you. What would have happened to you if you had had a health episode and were not on an MA plan? How did your MA plan compare to what the service you might have received under traditional Medicare?
If I'd have had traditional Medicare with my problems that I had, instead of being approximately $400 out of pocket cost because I stayed 2 extra days in the hospital when I had the open heart, if I'd have had traditional Medicare, it would have cost me $150,000. And that is a financial burden.
Now, what would happen to you if you would lose your MA plan that you have today?
Well, if I looked at the closest Medigap, and it would add about $700 to $800 a year to my cost, which something would have to be, because I am retired, something would have to be taken out of the budget to pay for the plan.
All right. Well, according to the Congressional Budget Office, the Affordable Care Act cut more than $300 billion from the Medicare Advantage program to spend on new government programs, new entitlement for not for seniors. What's your reaction to that?
Well, I've seen the cuts when I turned 65 5 years ago. We had 4 plans to choose from in Medicare Advantage plans. I'd always been with Blue Cross Blue Shield, so I signed up with them. I was informed the following year that they were dropping that plan. So I went to Optima. They had the next best plan. The next following May, I got my letter that they were dropping me. And the 3rd year, I went to Humana because they were basically the only one left. And in my area that I live in, Virginia Beach, Humana offers the only Medicare Advantage plan available. The others said they had to drop it because of the higher cost and the cuts.
Can you describe what your plan has done for you that you think may have prevented a hospitalization or from returning to the hospital?
Yes, sir. Every January and June, part of the plan is to go into your GP and have a thorough checkup. And, of course, I have to go to my cardiologist and have a thorough checkup. But the copay for those preventive is $0 for a GP. And, of course, my specialist is $35, which is easily affordable. So they keep me running.
If you could do a ballpark, how much do you think your health plan has saved you in cost, out of pocket, cost for the services you need so far?
Well, I know in the last 5 years it's saved me $140,000, $150,000.
Now, due to cuts in Medicare Advantage under the Affordable Care Act, some seniors may get to keep their plan, at least this year, but might still lose their doctor or lose affordable premiums or lose needed benefits. Have you lost your doctor or plan before?
No, sir.
Have you or your friends with Medicare Advantage plans experienced fewer choices and higher cost?
We've experienced fewer choices, but the low cost is still there. And in fact, with all respect to Ms. Stein, I don't know which Medicare Advantage plan they have, but they need to switch.
All right, let me go to Mr. Giese. What are the tools that CMS has at its disposal to legally reduce the impact of the cuts in the advance notice through administrative or regulatory means?
Some of the cuts are statutory, and some of the cuts are discretionary. So if Congress were to act, things like the ACA reductions, the demonstration plan, and the elimination and the risk score stuff could be changed. But if the other stuff that's discretionary is decided by CMS, so the rate book change, which are the trends in Medicare Advantage, we're not quite sure how CMS develops the trends. They're not really released to the public, so that could change. That's partially discretionary, and I would say that's the biggest one.
My time has expired, unfortunately. Chair Yield recognizes the ranking member 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask questions initially of Mr. Vanderwater. I've heard different views on whether the quality of care that Medicare beneficiaries receive from an MA plan is any different than fee-for-service Medicare. What's your take on the relative quality of care provided in fee-for-service versus MA plans?
Mr. Pallone, I think the short answer is that we don't really have clear data. I like to rely on Medicare Payment Advisory Commission. They're a good impartial source. And in their report from last March on Medicare payment policies, they said that, in quoting them, we have little information on which to base a comparison of MA quality indicators with those in private fee-for-service. That having been said, the evidence is mixed. There are some studies, which some of the members have referred to, that suggest that at least in some particular MA plans, quality may be better. There's other data, for example, that MedPAC cites that suggests that the quality is about the same on average in Medicare Advantage plans and traditional Medicare. So I think the right answer is that the record is probably mixed, and in some cases the quality is probably better, but we can't make that conclusion across the board.
Well, I think we should strive to improve the quality provided to all Medicare beneficiaries, both in the fee-for-service system and the Medicare Advantage program. Now, fee-for-service has undertaken new payment models such as accountable care organizations, Medicaid medical homes, and other initiatives, and Congress, including our committee, has made great bipartisan progress towards tying physician Medicare payment more closely to the quality of care provided. And now that MA plan payments are linked to quality performance, the plans are also working to improve quality. So what's your recommendation for steps we can take to continue to improve quality for all Medicare beneficiaries?
Well, I think you're exactly right to focus on the whole system. We're developing, as other witnesses referred to, a mix of payment models. We have not only traditional Medicare on the one hand and Medicare Advantage plans, but we're developing intermediate models such as accountable care organizations. I think that what Congress has done to encourage these different payment models is exactly the right thing. In your proposed SGR legislation, you have additional steps to develop models of that sort. The quality bonuses in MA plans, that makes sense. So I think in general that you're on the right track.
All right, let me ask you a question about the mechanics of how Medicare Advantage plans are paid. CMS reported that the proposed reductions will result in a 2.4 decrease to MA plan benchmarks in 2015, while the witness from Oliver Wyman testified on their recent report, and that's a report that I remind everyone that the insurance industry paid for, which claims that the plan's rates will be cut by 5.9%. And the plans are saying these reductions are going to either put them out of business, force them to hike premiums, reduce benefits, take other drastic measures. On the other hand, they said this last year too, and yet nothing really happened. But I know this is a very complex issue, and I'd like to get to the bottom of it. So let's just talk about the facts. Can you please explain the mechanics of how Medicare Advantage plans are paid, like what a benchmark is, what a bid is, and how plans payments are determined?
I'll try to give a simple answer, which will necessarily be a bit oversimplified. But as you say, the key factors in determining what a plan gets paid are, one, the plan's bid, which represents how much the plan estimates that it will cost to provide Part A and Part B services to a representative group of people. That is, people of a sort of an average.
Just so you know, I know because my time. What I'm trying to get at, and you know, is whether the reductions that CMS has proposed to the plan, you know, whether the reductions are to the payments or the benchmarks, and given the reductions in benchmarks, will the plans on average end up getting less money than fee for service? That's. But you know, go ahead.
Okay, the answer is that the reductions that are being discussed are the reductions to the so-called benchmarks. What the plans actually get relates both to the benchmarks and to what they bid and to other factors. So there's a lot of there's a lot of intervening steps, and reductions in the benchmarks don't translate one for one into reductions in the plan payments.
So can we say that the proposed reductions in benchmarks will on the average end up that the plans get less money than fee-for-service Medicare?
They will tend to, other things being equal, they will tend to reduce what the Medicare Advantage plans get paid. But on average, in 2015, MA plans are still going to get paid somewhat more than what it would cost to cover their enrollees under traditional Medicare.
All right. Thank you.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the Subcommittee, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. I'd like to address this to Dr. Liu and Mr. Giese. You heard the ranking member's question to Dr. Vandewater about the issue of quality between Medicare Advantage and traditional Medicare. Can you offer us your perspectives on that? Is there a difference in your estimation, a difference between the quality of care provided to the patient, to the enrollee in traditional Medicare versus Medicare Advantage? Dr. Liu, I'll start with you.
Yeah, thank you for that question. Yeah, absolutely, I can attest to that the quality of care delivered in a coordinated care model is far superior to a fragmented fee-for-service system, because you've got the whole continuum of care. Again, as I mentioned, the home visits coordinated with inpatient, outpatient visits, palliative care, and disease management. It's a team approach where you've got providers, nurses, pharmacists, social workers taking care of patients across a continuum. And, you know, even there was a mention about home care. Home care absolutely is the essential part of this piece. You take out home care, that leaves a gap in our system. You know, it's not an upcoding situation. It's a situation where we do actually recognize what could be admission drivers. We look for areas where a patient could perhaps be at a fall risk. So there's a lot of information gathered at a home visit. But absolutely, quality measures, there's no question. We can reduce bed days, we reduce lengths of stay, we reduce costs, we get better outcomes, and obviously patient satisfaction, and that's why members are wanting to migrate to Medicare Advantage.
Thank you. Mr. Giese?
Thank you. There are studies out there that show that the quality in fee-for-service is lower than in MA on average. In fact, a number of studies. But going beyond that, think about your parents, and if they're sick, they want to be taken care of. These people that sign up for Medicare Advantage plans are so happy that they're taken care of. They're called by the plan to say, you know, did you take your prescription? Did you get a checkup? And the people love this. That's so important to these people who sign up for these plans.
Can you, have there been any efforts to identify, we talk on this committee a lot about readmission rates for patients with certain diagnoses. Is there any evidence to point to, say, the readmission rate for someone who's hospitalized with congestive heart failure that's poorly controlled, gets hospitalized, gets toned up, gets sent home, they do better or worse on Medicare Advantage?
Readmission rates are lower in Medicare Advantage. There has been some studies that show that.
Well, let me ask you a question then, because part of this is we overpay Medicare Advantage. But you've just identified one of the larger cost drivers, and you say that's less with Medicare Advantage. So how can it be a program that costs more is actually costing less? It's paradoxical, isn't it?
Well, all of the
it's a trick question, Mr. Giese. I'm sorry. I couldn't help myself. We
All
deal with the Congressional Budget Office all the time.
All of the so-called overpayments to Medicare go directly to beneficiaries. The CMS, the rules for bids and the way the bids work, everything goes back to the beneficiary.
And I thank you for that. I did just want to point out, we deal with the tyranny of the Congressional Budget Office all the time, and it's bipartisan. It's by both sides of the dais feel the tyranny of the Congressional Budget Office. Mr. Little, I just have to ask you a question. Your testimony, your written testimony you provided, you said you were a small business owner?
Yes, sir.
So were you self-employed?
Yes, sir.
So being self-employed, you know, of course, you paid your taxes, your payroll taxes.
Yes, sir.
And for Medicare Part A, what was the payroll tax that you paid during most of your years?
Nobody in my organization was that old at that time.
No, but I mean, as you work, in your working years, you pay Social Security and Medicare.
Oh, yes.
Every paycheck, right?
Oh, yes, sir.
Do you remember what the percentage was that you paid for Medicare?
The FICA was 6.2. The Medicare was, I don't know.
It was 1.3. I have it on good authority. It is said it is 1.3, so let's stipulate that that's correct. But you were a small business owner, so you paid both for yourself, you paid both the employer and the employee contribution. Is that correct?
Yes, sir.
So you paid 2.6% of your earnings throughout your lifetime. So let me just ask you, do you feel that what you're receiving now in Medicare is an entitlement, or is that something for which you have paid?
Oh, I think it's something I've earned.
Yes, exactly so. And I just wanted to make that point. And it is then incumbent upon us to make sure you get the very best of what is available. And in your case, it sounds like that would be Medicare Advantage. I've gone over time. I'll yield back.
All right, Chair. Thanks, gentlemen. Now recognize gentleman Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. CMS proposed to disallow the use of the home assessment diagnosis unless the beneficiary received appropriate follow-up care. It is a good policy. Mr. Vandewater, I understand that plans were allowed to use beneficiary diagnosis information obtained during home assessment visits to increase their risk adjustment payment. Basically, what happened is that the plans were providing assessments for beneficiaries, finding that they were certain diagnoses and using that information for increased payment. But this is important, and the plans were not following up and providing the services the patient required as a result of that diagnosis. So the plans get more money, but the patient doesn't receive anything. It seems like it's a scam on tax dollars. Just so we're clear, can you please explain exactly what CMS has proposed?
Yes, sir. I think you actually provided a very good summary yourself. All I would add is that what CMS is proposing to do is not in any way suggesting that these home assessment visits cannot be helpful or useful, but as you say, that it's important that if a home assessment visit takes place and a condition is found, that the appropriate follow-up is provided. CMS is not saying that diagnoses identified during home visits are never going to be considered, but simply they do have to be recognized by a subsequent encounter with a doctor or a health professional to make sure that the appropriate follow-up is indeed taking place.
It seems like if they're getting paid for that assessment of that illness, they should be actually treating that patient.
Exactly.
Instead of just building up their payment. What's your take on this policy? Is it unreasonable to require a plan if they wish to receive higher payments for the identifying a diagnosis to require they provide that patient with those services?
I'm not sure we need to make the requirement, but we certainly shouldn't allow plans to get higher payments for the diagnoses if they're not followed up on.
In other words, that's a cost savings we could do, and that may be one of what we hear about is in Medicare is overpayment if they're not receiving the services that they're actually being paid for.
Yes, that's precisely what CMS is trying to do in the proposed policy.
Medicare Advantage overpayment often hurt beneficiaries in Medicare in the long run. Ms. Stein, I know that you've been a strong advocate for the strengthening of Medicare and ensuring it remains secure in the long run. That's why I have concerns about continuing to overpay Medicare Advantage. First, Medicare Part B premiums are based on program spending, so the extent Medicare is paying too much, it drives the beneficiary premiums up. Isn't that right?
That's exactly correct. The overpayments to the Medicare Advantage program are a problem not only for Medicare Advantage enrollees, but for all Medicare beneficiaries because their Part B premiums increase, and of course taxpayers pay more from Medicare as the whole.
We know that most beneficiaries have modest incomes, fixed incomes, and they don't have a lot of disposable income to pay extra to manage cares. How are beneficiaries affected by unjustified overpayments to private insurance companies while the minority who are enrolled in plans might see some additional benefits, but how the vast majority of Medicare beneficiaries are affected? It seems like if you're raising premiums for, and I'll take a number out of the air, 70% of the folks in my district, last numbers I saw, receive regular Medicare. About 30% do Medicare Advantage. So you raise the premiums for 70% to provide some additional benefit to the 30%.
That's correct, and I have to even question the additional benefits. I mean, what were mentioned were vision, which is usually some help with some eyeglasses, not very much, and preventive services, which are now zero-based in Medicare as a result of the Affordable Care Act. And I have not seen a great deal of actual coordination. When there is true coordination, I applaud it. But very often we have as much siloing of care in Medicare Advantage as we have in traditional Medicare. It's costing everybody more, even the vast majority who don't choose Medicare Advantage but stay in traditional Medicare.
Well, I only have a few seconds left, and I've heard some folks argue that we can't take away excess payments to plans and put them on parity with fee-for-service because some beneficiaries are low income rely on these plans for additional benefits, and they do. I know Medicare Advantage offers other things, but the problem is plans can change their benefits and cost sharing from year to year. So because a low income person has a plan with reduced cost sharing today, that plan doesn't necessarily have to offer that extra benefit over that year.
That's right. The plans can change the benefits from year to year so long as they're actuarially equivalent to Medicare, traditional Medicare. And I just want to say CMS did do a study in 2012 that showed that low-income people, people with high risk needs and health issues disproportionately disenroll from Medicare as they're dealing with those issues across the country. I have no skin in this game. My entire career is just representing mostly low and moderate income Medicare beneficiaries and protecting Medicare. That's all I care about here and getting access to care. And I think that the Medicare Advantage plan is providing way too much money for way too little uniform value, and it's hurting the Medicare program and most Medicare beneficiaries. I say that as an advocate, as a cancer survivor, and as the daughter of a woman who's just gone through an extraordinary neurosurgery that was available to her because she was in traditional Medicare. I can't understand why it would cost Mr. Little $100,000, and I hope he'll call my office if we can ever help him. We don't charge for our services.
Okay. Thank you, Mr. Chairman. I know I'm over time, but thank all our witnesses for being here.
Chair, thanks the gentleman. Now recognize the gentlelady from North Carolina, Mrs. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel for being here today. I just want to start off by associating myself with some of the comments, Dr. Liu, that you had made about how our seniors enjoy their Medicare Advantage plans and why it is so important that we work in Congress to protect them from these large cuts that will negatively affect 476,000 North Carolina seniors that I have the incredible honor to represent. I'm very concerned about this issue because I do believe it is a choice that our seniors are able to make. I think that our seniors are in jeopardy when they cannot make choices for themselves. Mr. Little has made a choice of what it is that he would like to see for his coverage, and I don't understand why we would consider jeopardizing that ability. When something works for someone, they should keep it. Isn't that what our president said? If you like your health care plan, you should be able to keep it. And yet now we're saying no, as a matter of fact, you can't. And Dr. Liu, thank you for your comments about patients in the home health setting. You know, our seniors want to take care of themselves. Our seniors want to be able to be independent. And if they're going to do a better job recovering from surgery or sickness, illness at home, I think that's where they need to be. And I think these are all the things that are jeopardizing our system. And to the point that Dr. Burgess was making earlier about savings in one part of Medicare only to spend more money in another. If we're helping to keep seniors out of the hospital or the inpatient setting, that is a dramatic savings within Medicare. So it only makes common sense to me that we would continue to advocate another program or Medicare Advantage that would help seniors be able to do that. You know, keeping people out of the hospital is the best way we can keep people healthy and safe in this country. There again, Dr. Liu, as a physician, do you believe seniors in rural areas? I have a large rural area in my district. How do you feel about seniors in the rural setting? How do you feel that they respond to the higher premiums or potentially no Medicare Advantage offered? I mean, how will that affect them?
Well, if Medicare Advantage plans pull out of certain markets, that will certainly leave seniors very vulnerable. You know, there are some parts of certain states that we do business in where there are very few Medicare Advantage plans. In fact, recently one plan pulled out of one of the states where we do business, and that left one dominant player, which is very vulnerable because if that one player pulls out, seniors are going to be left without physicians and without a network. But you know, hopefully that won't happen. And you know, to your point about seniors liking choice and having choice and having the better outcomes on the back end, that's all a result of what we've built, this coordinated care model. And what I consider an investment, not an overpayment, but an investment into this model that we have shown has worked, that we're threatening now to jeopardize by cuts. That's what I'm concerned about, because that's going to impact the physicians and the seniors.
Absolutely. And, you know, there again, to me, it's a matter of common sense. I struggle with the idea that the Obama administration and that CMS would choose to hit something that is working so well as Medicare Advantage when we have numerous programs that don't work at the federal level. As a fiscally responsible individual representing my constituents, this is simply not the place that we should go for savings. There are many others. And again, Mr. Little, I just want to thank you on behalf of my constituents, my seniors, for coming forward and sharing your stories and your experience with the health care issues that you had to deal with heart disease and cancer, because that is just so important. And your recovery and your ability to recover on your own terms probably had a lot to do with the Medicare Advantage plan that you chose.
Yes, it did. And one thing I'd like to interject that I didn't before, I've noticed it because I've been with a Medicare Advantage plan for 5 years. The costs are kept down mainly because of what they pay the hospitals, the physicians. Mm-hmm. I've noticed my checkup this year was $300. My doctor got $74. There it is. Mm-hmm. There's your savings. It's not costing the government any extra money. They're negotiating, but of course that's why several of the Medicare Advantage plans dropped out, because they couldn't get down to that price. Mm-hmm. And also, they're, with every claim that I do, and they send me what I did, they also send a letter. If you see any fraud or anything that was done that wasn't really done, please let us know immediately. So they self-govern themselves, and I think that's how they're keeping the cost down.
Well, thank you again for being such a great advocate on this issue. We truly appreciate it, and my constituents thank you.
You're welcome.
Mr. Chairman, I would like to submit for the record a letter that we sent to Ms. Tavener from the Doctors Caucus. Members of the Doctors Caucus put it together. I'd like to submit it for the record.
Without objection, so ordered.
Thank you, sir, and I yield back the remainder of my time.
Chair, thanks, gentlelady. Now I recognize the gentlelady from Virgin Island, Dr. Christensen. 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Stein, we've heard a lot today about Medicare Advantage plan choices and how seniors need to have a lot of choices of different plans. But like you, I believe that the most important choice that a senior can have is the choice of a doctor, the ability to access your physician or even a hospital where you're familiar with the services and you know you'll get good care. You spoke about Connecticut, where you're headquartered, and where there was a serious problem when Medicare Advantage plans abruptly dropped providers from their network, leaving beneficiaries who had selected a plan based on being able to continue to see their doctors in the lurch. To me, this highlights a very serious problem with Medicare Advantage. Plans make these choices to contract with a provider or not as a result of really business decisions. This is part of the downside of having private insurance companies whose main goal it is to make a profit serving vulnerable seniors. What recommendations might you have for how Congress and CMS could better protect seniors in Medicare Advantage plans from such disruption?
Thank you. I appreciate this opportunity. I think that the choice that people want of whatever age is the choice of who's going to take care of them and where they're going to be taken care of. And Medicare, traditional Medicare is pretty much an open network. You can go around the country. So, for example, my mother has just come from Western Connecticut to Eastern Connecticut to be in a nursing home near me. If she was in a Medicare Advantage plan in our state, that wouldn't be possible. So that you can go near family, you can choose pretty much all the doctors that are providing care, not all, but most. And also, as I said, Yale New Haven Hospital is no longer in the largest Medicare Advantage plan in our state. And that is certainly not because of quality of care. And that's because before these further level playing field of Medicare Advantage to the costs of traditional Medicare. One of the things I think is that if we were to, we should require, relook at the definition of an adequate network in Medicare Advantage plans and make sure that the definition is truly going to meet the needs of the people who enroll. We should look to providing beneficiary enrollees whose plans terminate contracts with their doctors, that they must be given notice, regardless of what the plan thinks of the adequacy of the network after that doctor and their hospital is terminated. If the physician or local hospitals that this person is known to use have been terminated from that plan, they should be given notice of that before it's effective. We should ensure clear, meaningful differences between the different Medicare Advantage plans that a given sponsor is offering, because it's very hard for people to know what they're choosing very often. We should standardize benefits within plans, as Congress intelligently did with Medicare supplement, Medigap plans many years ago. You can really tell apples to apples and know what you're getting. I would say, finally, perhaps most importantly, we should make sure that there is a true, even, level playing field in benefits and payments to traditional Medicare and Medicare Advantage. If we want people to truly have choice, they should have, besides of their doctors, between Medicare Advantage and traditional Medicare, we should make sure that the benefits are available in both. Now, because of the Affordable Care Act, we have mostly zero-cost preventive services in traditional Medicare. We should have the same reimbursement structure for those who provide care in traditional Medicare as in Medicare Advantage. We should offer prescription drug coverage in traditional Medicare, because people often go to Medicare Advantage now because it's the only one-stop shopping. It's the place where it's simpler. You go there, you get your prescriptions usually and your other services. so they feel they don't have that choice. Also, it's called Medicare Advantage. People think they have some advantage. They think they're getting something on top of Medicare. There should be a level playing field between the two operating choices, the two models.
Well, thank you. And I think some of those, especially the adequate network, could be applicable. There's a very troubling situation happening in Tennessee, Florida, and Texas in dental Medicaid managed care, where providers are being dropped. And I hope that maybe at some point we could have a hearing on Medicaid managed care as well. Thank you for your answer.
It's been a huge issue in our state, and it happened, we lost almost all our Medicare Plus Choice plans. And now, before these reductions and overpayments are in effect, United Healthcare dropped 2,250 physicians and hospitals and other care providers in Connecticut. That was a provider for one for every 200 Medicare beneficiaries in our state. It's been stunning. And I fear this is going to be used as an argument for even higher payments to Medicare Advantage, when if we could put that money into traditional Medicare, all 50 million Medicare beneficiaries would benefit, and taxpayers would pay less.
Chair, thanks. Gentlelady recognizes the gentleman from New Jersey, Mr. Lance, 5 minutes.
Thank you very much, Mr. Chairman. I recently had a constituent contact me to inform me that her Medicare Advantage plan had been canceled, and her new plan requires her to pay $600 per month, which is $50 more than her previous plan, with no indication that she will maintain her current plan benefits or the doctor she likes. It is my experience that this woman, my constituent, is not alone. According to Oliver Wyman Actuaries, New Jersey, the state I represent, will be one of the states hardest hit by these proposed cuts. Approximately 217,000 New Jerseyans are enrolled in Medicare Advantage, and they may see a reduction in benefits. Mr. Little, thank you for being here with us today, and I am hoping you can tell us a little more about your experience with Medicare Advantage, and I imagine it is similar to the experience of those in the district I serve who have reached out to me. Would you please explain, sir, to the committee why you chose a Medicare Advantage plan over traditional Medicare?
Well, I go to the gym.
Yes. My wife tells me I should go more often.
Well, you'll find it's really a convention of old people talking. We shoot the bull more than we exercise, to be exact. But when I first became of age, 65.
Yes, sir.
All the men that were in the gym and stuff say, well, make sure you look at the Advantage plan. That's the one to go with.
Yes, sir.
And so I Googled it and, of course, came up with 4 plans that were available. All of them were great. I took Blue Cross Blue Shield because I'd been with them all my life when I was in business in a regular plan. Of course, they dropped it the following year due to financial things. Then I shifted to Optima, and then they dropped it the following year. So then I only had Humana left. That's the only one left in my place. And they've been great. Whatever my GP says, when he found the mitral valve going bad in my heart, he immediately sent me next door to the cardiologist. And at 6 a.m. the next morning, they had my heart laying on a table and fixing it. And, of course, Norfolk Heart is one of the top 10 in the nation. There's never, ever in the last 5 years, between my pulmonary and my other physicians, anything about not being able to have the best service there is and the one of my choice. And of course, for the last 12 years since I retired, I've kept my same doctor.
When you had your open heart surgery, your primary care doctor worked with your specialist to ensure that you received the care you needed. Is that your testimony?
Yes, sir. He called right then. He said, you need to go right now because he heard something. And I went to the cardiologist, which happened to have his office next door, and he says, he picked up the phone and he said, be at Centera Heart tomorrow morning at 6 a.m. So it was fairly quick.
Thank you. Under traditional Medicare, without a supplemental policy, I think that some senior citizens could face financial difficulty, and perhaps even worse than financial difficulty, due to the unpredictable cost sharing from unexpected illnesses or hospitalization, and that is certainly one of my concerns. Dr. Liu, in your testimony, you described how Medicare Advantage incentivizes value and coordinated care, whereas that is not always the case with the fee-for-service Medicare program. Would you please elaborate on the importance of coordinated care and what this means for our nation's senior citizens?
Right. Coordinated care essentially is it's a team,
Yes.
not just physicians, the whole team of pharmacists and social workers and case managers working along a continuum of care. So it's not just when the patient comes into a hospital. It's home, hospital, office. It's throughout, no matter what type of problem that they have. And the other thing I want to note is we're not a health plan. We're a physician group.
Yes, sir.
And so we get 85 cents on a dollar that's passed to us. So what might look like a level playing field is not when it gets down to the physician level. And that's what we're dealing with when we're trying to deliver these extra services and provide the great care to the seniors.
Thank you. I think the testimony has been compelling, and certainly I hope that Medicare Advantage can continue, and that is certainly my perspective based upon my representation of New Jersey. Thank you, Mr. Chairman.
Chair, thanks to gentlemen. Okay, I guess Mr. Guthrie's here. Chair recognizes Mr. Guthrie, 5 minutes for questions.
Thank you, Mr. Chairman. Let me move over to the microphone so it'll be picked up. Thank you, Mr. Chairman. I have a question for Dr. Liu. Some people have suggested insurance companies are being overpaid for Medicare Advantage and rates should be cut to fee-for-service levels for equity. And what do you think the impact would be for patients if it was cut to fee-for-service levels?
Well, I think that the investment that was made has been made over the years to build this model, which I think now we're seeing the results of, and the seniors like it, and that's why they're migrating over. I think that was a smart investment. Now that we're facing cuts, which are really starting to roll in right now, just January of this year, I see it happening with our company. It's going to impact physician payments. It will impact programs and services that we're able to provide to seniors. And as these cuts continue throughout 14 and 15, I think that's just going to get worse.
And how long have you cared for seniors with Medicare Advantage plans? And what do you think they like the most about being
I'm sorry to hear that first question.
How long have you cared for seniors in Medicare Advantage plans, and what do you think they like the most about being in Medicare Advantage?
Our company's been taking care of Medicare Advantage patients for 20 years. And, what I think the seniors like is, again, the coordinated care that it's not just the primary care and the specialist and the case manager or the touches with member services. They like that comprehensive treatment. And obviously we give more benefits too. I mean, we provide transportation and a lot of other extra services.
Okay. Thanks. Mr. I think Geis or Giza, I'm sorry. Giza, okay. I'll practice it next time. Can you explain what types of choices plans face with the projected cuts under the ACA? What kind of choices will the plans have under these projected cuts?
Plans have a bunch of levers that they have at their disposal to try to ward off these cuts. Those changes, these adjustments include increases in benefits, increases in premiums, but of course CMS limits those the amount of premiums and benefits they can change in a given year. They also can try to incorporate more care management programs, but that sometimes is a leap of faith because in their pricing, if they assume a certain level of care management and don't achieve it, it could lead to not successful results. Plans could exit. They could change their service area. They could limit their network, making it a stronger network with more with better physicians, more quality care. That would help lower their costs as well.
But less choice for the patient.
But less choice for the patient.
So if you like your doctor, you may not be able to keep it.
Correct.
Well, thank you, Mr. Chairman, and I'll yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from Illinois, Mr. Shemkus, 5 minutes for questions.
Thank you, Mr. Chairman. I really appreciate your attendance. It's a great debate. I know there's some diversity of views. If Sydney put up on the slide, I always like to talk, when we talk about budgeting, that's the 2012 fiscal budget. The red is mandatory spending. You'll see Medicare's in there. The blue is discretionary budget, which is what we fight and shut down government about. Mandatory spending is spending that's we can't control. Medicare is part of that. Medicare, Medicaid, Social Security, interest payments on the debt. Sydney, you can pull that down. I do this all the time because if you have a national debt, it's based upon mandatory spending. And Medicare's part of that actuary problem that we have for future generations. Do you know why we're having this debate on Medicare Advantage? The president, through Obamacare, cut $716 billion from Medicare. And that's not disputed. Secretary Sebelius was right there. She admitted to testimony to me in front of this committee that she double counted Medicare cuts. So now we got to find the money. Now we're going after seniors in programs that we should have both. We should have traditional fee-for-service for those who want it, and we should have the Medicare Advantage plans that we promised them. This is the same debate we had last week on Medicare D. We were able to stop the administration from hurting seniors and cutting Medicare D program. And so that's why these hearings are very, very important. And I know it's tough, but, you know, facts and numbers are hard to dispute. That's why we're here, because of the attack on seniors from Obamacare and the cutting of $716 billion. Dr. Liu, only 20% of this cut has been actualized right now. My guess is there's still $300 billion more projected to go in the future. What do you think for this big portion of seniors, if that's the true number, what is the future of Medicare Advantage and Mr. Little and the plan and health care that he enjoys right now?
Yeah, thank you for the question. As I said, we just are starting to feel the pain of the cuts, 20% or less. And as these cuts roll out, it's going to be very difficult and very unlikely that we can continue at the same level of programs and payments to physicians.
So you're saying $300 billion more in cuts, Medicare Advantage might not even be available.
We're looking at double-digit cuts on 2014 plus 2015. I don't see how what we do can be sustainable.
All right, let me go quickly because time runs fast. And talk to me about the better health care aspects of Medicare Advantage and the diversity of population that you see in Medicare Advantage plans.
Better health care, we can reduce hospitalizations, readmissions, we get better outcomes, shorter lengths of stay.
Saving dollars.
Absolutely saving. I mean, investment with a great return. In terms of diversity, in the markets that we're in, it's all demographics.
Explain that. I mean, there's a senior population, so you're...
Ethnicities, socioeconomic levels.
Rich, poor.
Rich, poor.
Different ethnic backgrounds.
Different ethnic backgrounds.
Doesn't discriminate.
No. It's all comers, and it's not one particular demographic.
All right, let me ask you one more question, and no one's raised this, but I because of the funding problem, waste, fraud, and abuse is a big aspect on Medicare spending, right? And I've always argued because of fee-for-service, what do? We chase costs. We don't manage the illicit theft of the Medicare fund at the point of entry. We have to wait till there's 5-10 years of data before we go after the provider. You may not know this, but I would like for all the panel to look at what is a better plan to address the waste, fraud, and abuse that we currently know in Medicare today, especially fee-for-service, and does Medicare Advantage provide a more timely response to fraud? And I think, Mr. Little, you kind of mentioned that, did you not?
Yes, sir. I get a monthly statement from Humana showing everything I spent, and they caution you on the bottom if you have anything that you didn't have done, please call us immediately.
Dr. Liu, you want to jump in?
Yeah, I think that's the value of a population-based payment. It's a fixed payment that forces us to manage the care quality, and so we contract with good providers that won't commit fraud, whereas you've got a fragmented fee-for-service system that incentivizes volume, a lot of potential for fraud.
I appreciate it. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Louisiana, Dr. Cassidy, 5 minutes of question.
Thank you, Mr. Chairman. Intuitively, I like Medicare Advantage because I think it aligns incentives. Ms. Stein, I'm sure we can find horror stories with fee-for-service Medicare. I'm a practicing doctor, so I know some of those horror stories. But the nice thing I like is effectively it's a capitated payment in which physicians are at risk. If they do what I think Dr. Liu's organizations do, they go at two-sided risk with someone like Humana. So you align incentives, and frankly, you make money by keeping people out of the hospital or improving outcomes. If you don't, you lose them. Now, I'm struck, Dr. Liu, I'm so frustrated I can't open up my email account, but a physician practicing from Southern California sent me a document about the dual eligible project that's happening in Southern California. And in this dual eligible project, so far there is not a company which is certified. They all have the poorer rating for quality and outcomes than the better rating. Now, that is not your organizations. This is something specifically set up for the dual eligibles. And speaking to some folks like WellMed out of Austin, Texas, I gather that they selectively go after the dual eligibles, that they improve outcomes, that the focusing resources, knowing that if not, it breaks the bank. They're a two-sided risk, and so with prospective assignment of patients, and so that's where they earn the money, keeping that patient out of the hospital in better health. Would you like to comment on that, please?
Yes, thank you, Mr. Cassidy. That's absolutely correct. In our model, we don't make money unless we keep the population healthy. It's very simple.
And the patient can change at the end of a year, and you have quality indicators, so it's not like if you stiff them, you lose them, and if you stiff them, you get dinged.
Right. There's transparency in quality metrics, and so members can choose to opt out or switch to another plan.
So what percent can you give me of a typical plan that you might represent would be dual eligibles?
HealthNet? Is that what you mean? An actual plan?
Medicare, Medicaid. Pick a typical plan that if dual eligibles, would they be 10% of a enrollee group or 15%?
Okay. I would say out of the senior population, it's probably 20%.
Okay. And a lot of these would be in the special needs plans as well.
Special needs plan.
Now, there's been specific cuts targeted to the special needs plans. I assume that could, in particular, negatively impact folks who are most vulnerable. Is that a correct intuition?
Definitely. I mean, these patients are, by definition, have more medical problems, chronic illness, chronic disease, and require a lot more intensive management. And so without an infrastructure to take care of them, those are the ones that are really going to be hurt.
One of my concerns, I think, in some of the cuts they take away, they kind of make the home visit a second-class visit. Again, I treat a lot of cirrhotics, and cirrhotics would typically be in a special needs plan. You want to go home and you want to look at their diet, you want to look at their cabinet, you want to see where their salt is coming from. Cirrhotics are very sensitive to salt overload. I kind of like that special needs visit, that home visit, which looks at that. Again, any comments on the impact of decreasing the emphasis upon that?
Yeah, well, that's, again, another point. Home visits for the special needs patients that are bed-bound or home-bound, don't have transportation. It's essential that we get to the home and take care of them. To look at, cirrhotics that may have fluid overload, and you got to see what they're eating and what their diet is. It's important. You can assess a lot more from a patient in the house than you ever can in a clinic.
I once visited a patient of mine, and I saw he had a jar of salsa by his bed. I pointed out that salsa has a lot of salt, and so oh, really? I figure most men are pretty ignorant when it comes to their food. So, and he was a man. Okay. Now, Ms. Stein, you probably disagree with what I've been saying. What are your thoughts?
My experience tells me, as does the research, that and a report by CMS, that people with high medical needs and low income are disproportionately disenrolling from Medicare Advantage plans. And I don't think I'm here to talk about horror stories. As I said earlier, I have no skin in this game. My job is solely to represent low and
But in
Medicare
fairness,
Advantage.
you were mentioning the person who went to Florida and whose brain tumor wasn't covered.
One of your colleagues referred to my office, and yes, there are problems in both models, but the point is that we are paying as taxpayers, and your colleague earlier put up a pie chart which showed all the costs to Medicare, and the CBO says that we're spending as taxpayers $150 billion more than we would if these individuals were paid for in traditional Medicare.
We can argue about that. I will point out, and I'll finish with this, Mr. Chairman, that when Medicaid and Medicare pay differently, it disaggregates payment. When you disaggregate payment, you disaggregate care. So the dual eligibles are a particular interest of mine. That's why I've been looking at the demonstration project in Southern California. Very disappointed that the companies that are running this are being rated so poorly. And I do contrast that with some of the folks who are doing kind of subcontracting from Humana and others, and just seeing that they are getting superior outcomes. I think that kind of shows you the benefit of the special needs plans and a Medicare Advantage.
I actually probably I suspect that my organization represents more duly eligible home health and nursing home beneficiaries than anyone in the country. We have about 11,000 open cases right now. I just completed a training seminar with all the home health agencies in Connecticut, and one of the questions was, do the rules with regard to coverage for home health, these are home health agencies, for people in traditional Medicare also apply for people in Medicare Advantage plans? And I said, of course, yes. And there was general agreement in the group of home health agency providers that they have a much greater difficulty getting access to coverage, admission, particularly from the community for people with in Medicare Advantage plans.
We're out of time,
and earlier
so let me just say, the
discharges.
nice thing about it is that if the beneficiary doesn't like the MA plan, they can change the next year. And that's the wonderful thing about markets. If they're doing a poor job, we have to yield back. I'm sorry.
That's only helpful if the person can survive the year, and that often doesn't happen.
Gentleman's time's expired. The chair recognizes the gentleman from New York, Mr. Engel, 5 minutes for questions.
Thank you very much, Mr. Chairman, and Mr. Pallone. Thank you for holding today's hearing. Let me try to put some things in perspective here. In 2009, prior to the passage of the Affordable Care Act, the rates paid to Medicare Advantage plans exceeded that of traditional Medicare by approximately 18%. The Affordable Care Act required changes to Medicare Advantage payment rates to better align them with the costs associated with traditional Medicare. These changes were estimated by the Congressional Budget Office to save over $135 billion over 10 years, something that I think my Republican friends would love. The ACA did not make any cuts to the benefits guaranteed to all Americans over the age of 65, whether or not they are in traditional Medicare or Medicare Advantage. So I think it is worth noting that while Republicans are aghast that this administration is moving forward and implementing the provider payment cuts included in the Affordable Care Act, my Republican friends included and voted in support of these very same provider payment cuts in their budget proposals for the last several years. So to act horrified about the changes being made to Medicare Advantage now after voting to support them for years strikes me as being disingenuous. I know in the past there have been concerns about Medicare Advantage plans cherry-picking and seeking to enroll the healthiest of seniors, leaving sicker beneficiaries enrolled in traditional Medicare. Ms. Stein, in your written testimony, you mentioned a 2012 report from CMS that found disenrollment by individuals from Medicare Advantage plans back to traditional Medicare, and I'm going to quote what you wrote, continues to occur disproportionately among high-cost beneficiaries, raising concerns about care experiences among sicker enrollees and increased costs to Medicare, unquote. So let me ask you, given your organization often assists patients when they have issues with the Medicare program, can you elaborate on some of the challenges sicker beneficiaries sometimes have with their Medicare Advantage plans?
Yes, sir. Thank you very much. As Mr. Vanderwater said, Dr. Vanderwater said a little earlier, there isn't a lot of data about the actual health care outcomes, but we do know about disenrollment patterns. And you just expressed one of them, which is that people at risk, low income, and people who are ill tend to disenroll from Medicare Advantage plans. And that is because they have a much more difficulty in accessing a variety of specialists, different hospitals where they might get the treatment they want, being able to move around the country to be near their families because there are network limitations, and a variety of other problems. And we very, very often get calls from people who think that because the program itself is called Medicare Advantage, that they have got something on top of their Medicare, and when they find that they're ill and they need to go see a specialist and the doctor isn't in their network, they're terribly confused and didn't understand that when they enrolled initially. And while I don't think that Medicare Advantage plans are purposely closing their doors to people with particular conditions, we do know that of the 2,250 doctors and hospitals that were terminated in Connecticut alone, a very small state this year, by an MA plan, a lot of specialists who provide care for long-term illnesses, for instance, nephrologists, were on the termination list, and particularly in areas of low income in Bridgeport and other areas in our state, leading to significant problems for people who are ill with chronic conditions in MA plans.
Well, thank you. My home state of New York, which is, of course, right next to Connecticut, we have countless doctors, hospitals, and health insurance plans that have always made it their mission to provide quality care to all New Yorkers, regardless whether or not their patients have private insurance, Medicaid, Medicare, or pay for their health care costs out of their own pockets. And we also have several Medicare Advantage plans which focus on providing Medicare coverage for the dual-eligible and low-income population in particular, often with more than half of their plan participants eligible for Medicare and Medicaid or receiving a low-income subsidy. Yet an overwhelming number of these plans have found it challenging to achieve the 4 stars needed to earn a bonus in 2015, despite having scored high on improvement measures. So let me again ask you, Ms. Stein or Mr. Vanderwater, how can we better incentivize Medicare Advantage plans to take on more challenging beneficiaries so that these patients enjoy the same access to high-quality plans and choices available to healthier, more well-off beneficiaries?
Well, I think the improved risk adjustment, which we've talked about this morning, is actually one of those ways. What we want to do is make sure that health plans are encouraged to attract to attract customers through providing better quality service, and not to make money through attracting healthier beneficiaries. So I think that's, while this has been, criticized on the one hand, actually I think it's a very positive step.
Thank you, Mr. Chairman.
Also suggest that there was I think it was a MedPAC study in March of 2013 that showed that about 20% of dual-eligible special MA plans did score well on the STAR model and rating. And I think that we should look at what they're doing and encourage the other plans to do that, because apparently it is possible to score well on that rating.
Gentleman's time's expired.
Thank you.
The chair recognizes gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I would say to you all, and appreciate you all being here, I would say that my 83-year-old mother likes her Medicare Advantage plan. She's had to pay a little bit more for it than she had in some of the previous years, and even though we had Secretary Sebelius here April last year saying that the plans were costing less nationwide, that hasn't been my mother's experience. I surveyed, and that was a very small group of constituents in my district that responded, but they responded that theirs were either staying the same or going up, so it does appear that there are some increases. Has that been your experience as well, Mr. Little?
They didn't increase the base, but I've noticed this year that I'm paying 25% more for my prescriptions.
Okay. I understand that. Mr. Giese, did I get it right? All right. You've been kind enough. I'm just wondering if there's something we haven't touched on. I've got some questions for Dr. Liu, but I don't have any questions for you. But I thought maybe there was something that you've been sitting here that you wanted to say that you haven't had an opportunity to get out, and I'm going to give you that opportunity.
No, not really.
All right. I appreciate that. I just, we sometimes have folks here and you have a lot of very good witnesses, and then somebody, because of the way the flow of the discussion is going, they get left out, and I always hate to see that because I know that your time is just as valuable as everybody else's, so I do appreciate that.
A lot of people have read the report, I can tell, and have quoted it, and so.
Very good. Dr. Liu, according to the CBO, the ACA cut more than $300 billion from Medicare Advantage programs to spend on new government programs that weren't necessarily for seniors. What types of important health benefits do you think that the MA plans help provide to seniors that would have to be cut if the proposed cuts occur?
Well, I think we have to look at what the investment from prior years did into building up the model, the coordinated care model, and all the additional benefits that the seniors get. And we'd have to look at, how can we even sustain that with the 10% cuts over the next 2 years? So you're looking at jeopardizing programs, reduced payments to our physicians, and subsequently it could impact care to the seniors.
Now, I don't know anything about the Connecticut situation, but with those 2,200 some healthcare providers that were eliminated from an MA plan there, is it at least reasonable to assume that maybe they couldn't afford to pay those doctors the rates that they previously were paying, and that may be one of the reasons? I know it's got to be more complicated than that, but could that be one of the reasons why?
That's likely one of the reasons, sure.
Yeah. In a recent letter, more than 140 physician groups called on Medicare officials to hold MA rates flat. In the letter, they said cutting Medicare Advantage year after year will result in deterioration of the care coordination infrastructure, and seniors will see a deterioration of benefits, and we are worried we will ultimately move back into fragmented fee-for-service care delivery models. This would be a bad outcome for seniors and a step backward on the health care delivery system. You've been seeming to say the same thing today.
Exactly that same thing, yeah.
And can you elaborate on that some?
Yeah, well, I think then rather than going backwards, is we need to use the platform that we've built to build more coordinated care. And even some of the newer models within fee-for-service, such as ACOs, medical homes, how can we take all that we've learned from the Medicare Advantage coordinated care model, how can we use that to build the newer models that we're trying to do in fee-for-service? But this impacts all of the health care delivery system. It's not just Medicare Advantage. It's care for everybody in the country. And so, if we want to really transform the delivery system, we don't want to touch Medicare Advantage and all that we've built.
All right. I appreciate that very much. Thank you all again. And, Mr. Chairman, I yield back.
Chair, thanks, gentlemen. And now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for questions.
Thank you very much, Mr. Chairman. I want to point out that there are a lot of things going on at the same time. Additional subcommittee and another committee that I'm involved with, so I haven't been here the full time. But, Mr. Chairman, I'd like to ask unanimous consent to insert my opening statement in the record.
Without objection, so ordered.
And there's an awful lot of fear-mongering going on about Medicare Advantage program, and it's not based on the facts. The Democratic staff released a memo this morning. The first point is that independent analysts and the financial markets do not agree with the industry's dire claims about the future of Medicare Advantage. And the second point is that this scare campaign is not the first time the industry has cried wolf about common sense reforms being flat wrong. The memo looks at the facts, not anecdotes or claims by industry-backed groups. And here are the facts we point out. Since the ACA was enacted, Medicare Advantage premiums are down almost 10%, and enrollment is up 30%. After CMS released its payment notice and the industry claimed the sky was falling, independent experts examined the issue and found that the industry is wrong. They predict the future is bright for Medicare Advantage, and as a result, insurer stock prices have risen, not fallen, since the CMS announcement. And this is not the first time the industry has cried wolf on Medicare Advantage or other common sense reforms. They said that the ACA would destroy Medicare Advantage, but it is stronger than ever. They said the requirement that they pay back rebates if they spend more than 20% of premiums on profits and overhead would put patients at risk, and it did not. Instead, it's resulted in more than $1.5 billion in rebates and $5 billion in lower premiums. Mr. Chairman, I would like to ask unanimous consent to insert the memo I referred to in the record.
Without objection, so ordered.
And the next thing I want to ask in the time I have is, Mr. Vandewater, we've heard a lot today about the Medicare Advantage changes in the Affordable Care Act. These changes strengthened the program, in my view, and helped improve the solvency of the Medicare Trust Fund as well, preserving Medicare's health for a number of years. If you listen to my colleagues on the other side of the aisle, you'd think these cuts were killing the program. But in fact, this has not been the case. Could you comment on what has happened, what has happened to Medicare Advantage enrollment and premiums since the Affordable Care Act was enacted?
Yes, Mr. Waxman, I'd be happy to. In fact, in my prepared statement, I cite some of the same figures that you've just reiterated about how enrollment has indeed grown over the past several years and how premiums have actually gone down. And you're absolutely right that the efficiencies in Medicare payments that were enacted as part of the Affordable Care Act have indeed made an important contribution to strengthening Medicare's Hospital Insurance Trust Fund. My recollection is that the CBO estimate is that the Affordable Care Act extended the life of the Hospital Insurance Trust Fund by roughly 8 years.
If the health insurance companies like getting more money and the 30% of beneficiaries who are in these plans are generally happy, why not keep overpaying them?
Well, one of your colleagues on the other side of the aisle showed a chart a few minutes ago showing that Medicare, as we all know, is a substantial part of the federal budget, and we are concerned about reducing projected large deficits.
Well, they're pretty quick to give us ideas about how we should make the elderly pay more for their health care costs, but they don't want to reduce the cuts of overpayments to these Medicare Advantage plans. We've heard a great deal about Obamacare cuts to Medicare Advantage, but didn't the Republican budget led by Representative Paul Ryan include the very same so-called cuts that were in the Affordable Care Act?
Yes, it did.
I've been in Congress for 40 years. That's why I'm retiring, among other reasons. And I remember when we first made Medicare managed plans available for Medicare reimbursement if the beneficiary chose to go in such plans. And we had it less than what the fee-for-service would be because they selected out some of the lowest risk people. And the fee-for-service were carrying the highest risk. We went from a little less than what fee-for-service was to way more than the fee-for-service costs. Without doubt, in my opinion, as I look at this program, Medicare Advantage is important. It serves a very useful purpose. The beneficiaries are free to choose it, and many of them are very happy. But that's just not a reason to overpay them. Thank you, Mr. Chairman. Yield back my time.
Chair thanks the gentleman, and now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it very much, and I've been going back and forth as well from CMT, but this is a very important hearing. Mr. Giese, 40 to 45% of my seniors in my district, and I have over 100,000 seniors in the Tampa Bay area. I represent that area, the 12th District, Congressional District of Florida, are on Medicare Advantage, 40 to 45%. That's higher than the national average. So they really love their plans, and they love the fact that they have all these choices. I'm concerned with some of the changes that CMS is doing to their risk model. It seems to me that CMS is ignoring or not factoring in certain chronic conditions when determining their risk model. When considering the risk adjustment, CMS seems to ignore or not count patients with certain chronic conditions. Where is the impact of the 2014 changes to the risk model on sick and frail Medicare beneficiaries, in particular to those in the special needs plans area?
Well, changes to the risk model result in reductions in payments to plans, which means more the plans have to react by increasing benefits to everyone, but in particular to the poor and actually sicker people who pay the cost sharing. So these people will have to pay more as a result of changes to the risk adjustment model.
Thank you. Next question is for Dr. Liu. In 2015 advance notice, CMS eliminated the home health assessments as part of the risk model. This is what I understand. As I understand their change, CMS would only count the diagnosis identified in a home visit if and when it was confirmed in a later in-office doctor's visit. Can you explain the dangers of the payment change related to the home-based health assessments, especially for the elderly?
Yes, thank you. As I had mentioned, home visits are part of the continuum of care. And you take out home care and the benefits, it leaves a gap. If you're only going to count a visit or a diagnosis obtained at a visit if the patient's followed up in the office, a lot of these patients go to the hospital because of, that's the value of going to the home, early detection, catching something, and as opposed to a 911 phone call and something a lot more serious. The patient can be sent to the hospital for care. So, to only count a diagnosis where the patient has a follow-up visit in the doctor's office, that's very narrow in scope, and it really discounts the advantage and the benefits of a home visit.
Thank you very much. Mr. Giese, this question is for you. For all these cuts to Medicare Advantage, these plans are dependent on the star ratings to survive. However, it seems to me that special needs plans may be disadvantaged because of their unique population. Can you describe some of the challenges that special needs plans face in the star rating program?
Sure. First of all, it's, a lot of the star ratings are based on survey data, and sometimes it's hard to get to these people. Some of them are homeless. Some of them, they don't know where they live. So it's hard to find them in these surveys. So special needs plans tend to have lower star ratings because we can't find the people, and they don't respond well to the survey as well.
Okay. Now, if the cuts for Dr. Liu and Mr. Giese again, if the proposed cuts occur, what kind of benefits would no longer be provided to seniors, in your opinion? Example of some of the benefits that they might lose if the cuts take place.
Well, from our delivery side, I think you're going to jeopardize all of the extra home visits, perhaps. I mean, that would be one example. And we have a lot of programs built around, again, the continuum of care, visits from pharmacists and social workers, which have sufficient costs. And, if we're on a budget and our revenue is reduced, that's obviously going to jeopardize a lot of our programs.
Remember that cuts and benefits are not just additional benefits over Part A and B. They're also changes in cost sharing. So if the plan has to increase their cost sharing, that is a reduction in benefits.
Okay, very good. Thank you very much. I appreciate it. You're back, Mr. Chairman.
Chair, thanks, gentlemen. That concludes the questions from the members who are present. There are several committee meetings going on, so other members will have questions. We may have follow-up questions. We'll submit those to you in writing. We ask that you promptly respond. I recognize the ranking member for a UC request.
Mr. Chairman, I would just ask unanimous consent to submit for the record some Democratic comments in a letter to CMS.
Without objection, so ordered.
Thank you.
Thank you very much for your testimony. This is a very important issue, and we appreciate you coming today. And I remind members that they have 10 business days to submit questions for the record. Members should submit their questions by the close of business on Thursday, March 27th. Without objection, the subcommittee is adjourned.